All right, welcome everyone to today's webinar titled Behind the Scenes Navigating Peer Review and Revisions, hosted by Circulation Cardiovascular Imaging. I'm Jiwon Kim, and I'm really thrilled to be moderating this session alongside my co-host, Dr. Kaz Negishi. We have a really exciting session ahead. We have presentations and we'll have discussions with leading experts in cardiovascular imaging. So if you've ever submitted a manuscript and wondered what happens next, who reads it, how decisions are made, and what makes for a strong response to reviewers, you're in the right place. So our goal today is to provide you with an inside look at the editorial and peer review process straight from the experts who shape it. And we're really lucky to have esteemed editors and authors who will share their insights today. So first, we're really honored to be joined by two leaders in the field of cardiovascular imaging research and publishing. Dr. Robert Gropler is the editor-in-chief of Circulation Cardiovascular Imaging. We also have Dr. Fabien Hyafil, associate editor of Circulation Cardiovascular Imaging. And they'll share their insights on what happens behind the scenes after a manuscript is submitted and how editorial decisions are made. So the outline for today's webinar is such that we'll start off with author presentations. We have two outstanding research teams who'll share their manuscript journeys from design to revision and then to publication. And next, we'll talk with our expert editors and ask them questions regarding how these manuscript decisions are made. We'll talk about some of the common pitfalls and best practices when submitting a manuscript. And most importantly, we would really like to answer your questions. So please do go ahead and submit questions in the Q&A or chat throughout the webinar, and we'll get to those as well. So with that, for our first author presentation, we have Dr. Thomas Treibel and Dr. Jonathan Bennett, who will share their experience with their manuscript on myocardial remodeling post-aortic valve replacement. Dr. Treibel is an associate professor at University College London and is a leading expert in valvular heart disease and multimodality imaging. And Dr. Bennett is a cardiovascular imaging fellow and PhD candidate with a focus on cardiac MRI and heart valve disease. We're really thrilled to have you both here today, and we're really grateful for your time. And the floor is now yours.
Thank you, Jiwon, for the kind introduction, and thank you for the editorial team to allow us to present this work as well as our journey to get this manuscript to publication. So let me just share the presentation. Brilliant. I hope that will project across. So I'm Tom Treibel. I'm coming from London, and together with Jonty Bennett, we'll present the data. These are our disclosures. We're coming to you today from Barts Heart Centre, which is one of the oldest hospitals in the United Kingdom, which is situated very closely to St. Paul's Cathedral in the centre of London. And the work is part of University College London itself. I will hand over with that to Jonathan, Jonty, who will present the data itself, and I will come back to you in a little while to then talk about the journey itself. Jonty, over to you.
Brilliant. Thanks, Tom, and thank you very much for Circulation Imaging for inviting us here today and allowing us to present our science and talk about the peer review process. I think I'm going to present the science part of it. So we all know aortic stenosis induces significant afterload on the left ventricle, which induces left ventricular hypertrophy and fibrosis. And there's cardiomyocyte hypertrophy and also expansion of the extracellular matrix, which is comprised of both replacement fibrosis and diffuse fibrosis. This fibrosis is adverse and has functional impacts both pre and post AVR. It's associated with ventricular stiffening and diastolic dysfunction, impaired oxygen and nutrient delivery at the cellular level, arrhythmogenic risk, and adverse long-term outcomes with relation to heart failure and cardiovascular events. We know that successful aortic valve replacement is prognostically significant and there's a significant reduction in left ventricular hypertrophy of around 15 to 20% at 1 year. We know that those with a greater reduction in LVH have reduced hospitalization rates. Previous work from our group showed that at 1 year, there is regression of both the cellular and extracellular compartments. However, further research after that showed that actually a significant proportion of left ventricular hypertrophy regression goes actually very early after AVR, within 1 month. May we go to the next slide? And what we wanted to assess is, what is the relative contribution of the cellular and extracellular compartments in this early LVH regression? Next, please. We undertook a prospective cohort study at Bart's Heart Center between 2021 and 2024, recruiting adult patients, all who had severe symptomatic aortic stenosis. Patients underwent comprehensive cardiac MRI pre and post-aortic valve replacement at a target of 6 to 8 weeks post. We have an outline of our cardiac MR protocol on the bottom left, which in short include predominantly T1 mapping and ECV quantification. We used a validated AI algorithm to define our volumes and mass, and also LGE imaging. We used Circle software for feature track and strain and generation of global longitudinal strain. So to calculate the cellular and extracellular component of the heart, we had to convert the mass into volumes. So we take the index left ventricular mass divided by 1.05, which is the specific gravity of myocardium, and this makes it into a volumetric. And then for the extracellular component, times this by the ECV, such as 25% would be considered relatively normal. And then for the cellular volume, the opposite of this, so 1 minus ECV percentage times the left ventricular index mass. Next, please. So in total, we recruited 41 patients, all of which had severe symptomatic AS. From a demographics perspective, 80% of the patients were male and 20% of them had coronary artery disease. I think looking at the echocardiography and marrying that up with their baseline structure and function, this is the phenotype of predominantly high gradient, high flow, preserved ejection fraction AS. So patients had a Vmax of greater than 4, and ejection fraction was only less than 50% in 3 out of the 41 patients. In total, GLS was reduced at minus 15%, and this is lower compared to normative values within the CMR imaging modality, and mass index was elevated in 43% of patients when taking age and sex adjusted values. Next, please. So our patients underwent intervention, of which 60% of them were surgical aortic valve replacements, the remainder TAVI, and 5% had CABG. And we followed up our patients at just shy of 8 weeks. With regards to remodeling, well, firstly, they symptomatically got better with improvement in NYHA and CCS, and their gradients significantly reduced. With regards to remodeling, if I take you to the graphs on the right, there was a significant early reduction in left ventricular mass index, 15% reduction. And this was accompanied by a slightly counterintuitive increase in ECV percentage of nearly 3%. And this increase in ECV is driven by, if we go to graph C, there is a significant 18% reduction in the cellular volume of the heart early on. And then there's also additionally a smaller but significant reduction in the extracellular volume at 8 weeks as well, which is a major finding within our research paper. However, because this reduction is unbalanced with a greater component coming from the cellular compared to the extracellular, there is an increase in ECV. Next, please. So how did this relate to, this early remodeling relates to global longitudinal strain? So these graphs are slightly tricky, but I'll take you through them. If we look at the top left graph A, so patients that had an increase in their ECV percentage had a worsening of their GLS in the sense of they went from minus 14 to minus 12, and that's why they're defined as positive on our graph, and that's why there's a positive association. There was a trend towards, but non-significant in our study, that those that had a greater reduction in cellular volume had a worsening of GLS. And those with a greater cellular reduction, change in cellular reduction, and that had a greater cellular hypertrophy at baseline. There was no significant associations detected with regards to left ventricular mass index, nor with extracellular volume index. Next, please. So in summary, what we demonstrated in our research paper is that early after successful aortic valve replacement for severe AS, there's an unbalanced early remodeling with a greater cellular reduction compared to an extracellular reduction, which is associated with an increase in ECV percentage. However, what we did also detect is that there is a degree of early dynamism with extracellular volume reduction at this early rate, but it is significantly less than the cellular compartment. While across the cohort there was no change in GLS, certainly no, we did detect that those with an increase in ECV did actually have a worsening of GLS. And then if we just go next, I'd just like to thank all of the participants that took part in this study, and just acknowledge everyone on this slide who are too numerous to name, who contributed into making this research happen. And then I'll pass you back now to Tom to discuss the review process and make this a bit more interactive.
Thank you, Jonty. I just wanted to quickly summarize and put this into context. So at 8 weeks after AVR, we see a 15% reduction in the hypertrophy. And because there's a 2.5 times greater reduction in the cell volume than in the fibrosis volume, we get an increase in the ECV. And this unbalanced early regression was accompanied by worse global longitudinal strain. If we contrast that, what we have previously seen in a separate cohort at 1 year, where we have a slightly greater regression of nearly 20%, there the cell and matrix regression are similarly. Still, we've got greater cell regression than matrix regression, but only about 15% more. And the increase in ECV is only half of that. So it's really the stiffening early on of the heart due to the greater cell volume, which may be a therapeutic target. Because here we need to think about the antifibrotic therapy that may improve the early heart failure admissions that we see early after valve replacement. So it is the adverse remodeling pre-AVR and then the LVH regression after AVR that are the targets for potential therapy. Now, how did we get there in the paper? This was a sub-study of a much larger study, a 200-patient outcome study, where we're looking at remodeling at 1 year. The data was acquired throughout the first, second, and third waves of COVID in London. Well, the second and third waves of COVID. And therefore, we were challenged by getting patients back into the hospital. It was challenging enough to fit cardiac MRIs in and other visits during this challenging time. So after 26 patients and just before the third wave, we saw a significant regression in an interim analysis in the left ventricular mass and the cell volume. That time, we did not see a fibrosis regression, and therefore decided to stop with the sub-cohort study. Jonty wrote the data up, presented this at a European conference, and then submitted this as a short report, as this was a relatively small cohort, but with a significant finding. And the data was then eventually submitted in October 23 to Circ Imaging as a research letter. Now, 6 weeks later, we got a reply, including a direct email by Professor Hyafil, which suggested that the journal would be interested in our study, but because of the small number of patients, were keen that we would recruit more patients and encourage the submission as a full paper, with the important caveat at the bottom that owing to the vast amount of work required, they would not wish to encourage revision by itself. And I think if we perhaps at this stage get perhaps a feedback by the editors about the discussions, and I then perhaps come back with the remaining journey and to publications. Fabien, you might be able to comment on the discussions at that time.
Yeah, I can first congratulate for the nice presentation, the great research work. I think you did a great work, and I think it's as an editor, we're always happy to see this getting published and becoming a very nice paper published in Circ Cardiovascular Imaging. So my first word is congratulations for all this work. The second, so this was the first step. I have to say that it's at Circ CVI, what I like as an associate editor, and is that we work as a team. It's not like a personal kind of decision. It's always shared with our other editors, and of course with Rob Gropler, the editor-in-chief. So I'm not the only one handling this paper. This paper was presented during our editorial board meeting. And just to give some more details about how it works is that we collect then the opinion of the reviewers who give us kind of, and as a reviewer, we expect them to give us kind of the context of the research, because we don't have expertise in every kind of field of cardiovascular imaging, provide us the strengths, the weaknesses, the possible bias in the research, and also make comments to improve the paper, constructive comments. This is very helpful for us. And then we try to summarize, as an editor in charge of a paper, we try to summarize all these points, and we present this at our editorial board meeting. And so your paper was presented. The strength was really a very good methodology in terms of cardiac MRI. The way you performed it was kind of state of the art. But we were concerned, as you say, about the small number of patients. And the message initially was that there was no change in extracellular volume. And we were concerned that maybe the number of patients were too low and you might miss this change. The other concern was that there were a small number of patients with low left ventricular ejection fraction. And this is key in terms of, when you look at fibrosis, of course, the fibrosis is higher in patients with low EF than in patients with normal EF. And so and that's why we ask you at this point to expand the number of patients. We also looked into your reference, in terms of clinical trials, what we were expecting to do for these patients. And then we found out that there were many more patients that were supposed to be recruited in this study. And so this is something we do as editor. We try to look at what you publish, in clinical trial, if it's a prospective study. We look also at what has been formally published. We found this paper, in fact, that shows this similar findings after 1 year, with earlier changes in the paper. And this is kind of the work we do as associate editor. And that's why we came back to you after discussion with Rob Gropler and other editors, that we would give you a chance, because we think it's a very good paper of value and the results are interesting, but we want to have more patients to confirm these results and understand why you didn't include more patients in the study.
Thank you both. Taking even one step back further, Fabien, can you comment, for those who may not be as familiar with research letters, can you comment on sort of the differences between a research letter versus a full manuscript in terms of the content, the scope, and the expectations? And can you comment on whether there are any differences in terms of the way the two different types of formats are handled from an editorial standpoint?
Yes, I think so. A research letter is much shorter. I don't have in mind. I think you have maximum 2 figures, I think, or 1 figure that should summarize all the results, and it's much shorter. So Carrie's telling me 800 words, 1 figure or table, so it's much shorter. And I think it's a good format if you have kind of an original finding with methodology that's relatively simple, kind of straightforward hypothesis results, and that you don't need to expand too much the results or the discussion in this kind of format. It's mostly that's why I think they submit first as a research letter. If you have a small group of patients, there was kind of a very clear message in this first paper. And so I think this is the typical format what we expect in research letter, either small group of patients, kind of original findings, and that need to be confirmed with a relatively simple message. Manuscript is the best format if you have kind of complex methodology or new methodology in terms of imaging that you need to kind of provide more information in your methods. Also results, if you need to kind of confirm there's no bias, or perform different ways of looking at your results, and then you need to expand your results section. And also if you need also quite a large discussion. If it's to put in perspective what you found in your manuscript, I think this is typically what we expect in a regular manuscript.
Fantastic. Thank you for that. I think it's very helpful to be able to understand these formats and what the authors should be considering when they're making their submissions. And so with that, Tom, I'm curious to hear your take on in terms of what your thoughts were when you received this response and your decision to go ahead and expand this to a full manuscript. I'm curious to hear about the next steps.
Yeah, absolutely. I think we are still in the challenges of COVID at the time, and the plan originally hadn't been to do this early follow-up. And it was opportunistic that we were able to bring some patients back. But clearly, I think we were encouraged by the positive reply and by Professor Hyafil reaching out. And we were able to divert some resources, additional money. Jonty was able to refocus and recruited another, I think, 13, 14 patients. And indeed, what we then saw was that there was not only a significant cell regression, but also, as we presented, a fibrosis regression. So clearly, I think the hunch by the editors was correct by us to expand the cohort. And I think expanding, it's actually more difficult to write a short paper of 1,000 words than having a long paper of 5,000 words. So I think expanding that was not a problem. So we resubmitted that, got a second decision back that requested then to add global longitudinal strain, which then Jonty duly also added. And then later on, we got after a third submission with some statistical input, then the go-ahead for publication, which ultimately the whole process was nearly 1 year. So I think this was not a short process bringing that all together. But yeah, how did we feel? I think great that it all worked out and we have got a paper published, but it's clearly a longer journey and with some motivation talk to the fellow as well, who needs to continue working on that.
If I can comment, I think what your paper was one of the longest I handle in the past 2 or 3 years. So I think it's not usual that it takes so long. I think, of course, if you ask for more data, you need to collect this data. This is where these are one of the challenges when you want to resubmit a paper and you need to provide more data. Analysis is maybe easier and can be, if you have the people, you can do it. But if you need more inclusion of patients, this is really quite a challenge. And I'm happy that you managed to do it. And I think at the end it was worth the efforts then.
Absolutely, yes.
For sharing that. Yeah, I will add that we picked this paper on purpose as an outlier for sake of discussion, and I appreciate everybody sharing their thoughts here. Related to the revisions, I think for many early stage investigators and trainees, having to do a lot of revisions, I think can feel daunting at times. From both the editorial and the authorship standpoint, based on your experience, is there any advice that you have for early career researchers in terms of how to handle multiple rounds of revisions? Is there any strategies or mindsets that you found to be particularly helpful for authors?
Yes, I think I've been through this, so I know, how you can feel and sometimes how challenging it can be to get to receive this kind of, letters with a lot of comments by the reviewers and things to add to the paper. It can be discouraging, but I think at the end, the idea is to really try to improve your paper. And so what you have to really read carefully the comments of the reviewers and the comments of the editors. And in there, you will find and you have to try to understand what are the key points that needs to be answered to get your paper at the point where it can be published in cardiovascular imaging. And so, and then you have to decide if you can reach the point, answer adequately to these key points. Maybe there are small points you can maybe find ways to answer and not completely answer these points, but they're really, usually we try to provide you some key points that for us are important to make sure that the paper is of quality and that we will be ready to publish it. And I think you have to make this work. It's important to read carefully, try to understand why these points were raised by the reviewers or the editors, and see if you can answer either with your data or by adding new data these points. In some cases, you might write an email and a letter to the associate editor in charge of your paper and ask for more information if you're not sure about what is clearly asked, or if you have any doubt, rather than to do work and at the end it's not worth the efforts. I think it's better to ask at this point some clarification if you're not sure about what is needed. But I think it's important. This step is very important to understand really in depth what are the points that need to be answered if you want the paper to be published.
That's very helpful. Very helpful.
Yeah, if I can, Jiwon, I can just add a couple of things too. First, congratulations on the paper. It was very well done, both in terms of the end product and how you presented it. And Fabien did a fabulous job honchoing it all the way through. My own advice is when you get reviews back, don't even read them the first day. Just put them away for 24 hours and then get them and then read. Because a lot of times you may not really pick it up because there's a bit of emotion tied to what's come back, depending upon what the revisions are. Second request is, or suggestion is, have multiple people who are co-authors look at the revisions, get their input. And I think the third one is your answers don't have to be really long. They can, I mean, we get back responses to the queries and they're actually longer than the paper. And we don't, I mean, if I can just suggest, we read a lot of stuff through the course of a week. Just get to the point. Here's what we think. Here's how we think the data makes sense or doesn't. Just answer the question very quickly and clearly, but it doesn't have to be a whole page or 2 pages of an answer. And just because again, think about from the other side, you want to get your point across in the least amount of time so they can. I'll be honest with you, it'll be viewed more favorably than someone having to read through a very, very long response to the reviews.
Fantastic. Thank you very much to the editors and to the authors. I think that was all incredibly helpful. We have another manuscript that we'll discuss. Kaz, go ahead, please.
Thanks, everyone. That was interesting paper. So I'd like to introduce next speakers, Drs. Mahesh Vidula and Dr. Paco Bravo from the University of Pennsylvania. Dr. Vidula is the Assistant Professor of Clinical Medicine at UPenn. Clinical focus is the multimodality imaging, and also research focus is inflammatory cardiomyopathy and valvular heart disease. Dr. Bravo is the senior author of the next paper and also the director of nuclear cardiology and cardiovascular molecular imaging of the University of Pennsylvania. The title of the paper is the relationship of ketosis with myocardial glucose uptake among patients undergoing FGT PET-CT for evaluation of cardiac sarcoidosis. Without over ado, pass it to you both.
Great. Thank you so much for that introduction. I'm going to share my slides here. All right. So yeah, thank you again for the invitation to participate in this webinar. So I'll go ahead and start here. So we'll be presenting the relationship of ketosis with myocardial glucose uptake among patients undergoing FDG PET-CT for evaluation of cardiac sarcoidosis. And thank you very much to my mentor and colleague, Paco Bravo, for his mentorship with this work. So let's see. Great, these are our disclosures. And so as you all know, FDG PET is the non-invasive standard for imaging myocardial inflammation related to active cardiac sarcoidosis. And preparation with the ketogenic diet is required to induce a metabolic switch that suppresses physiologic myocardial glucose uptake and thereby allows us to then visualize the pathologic FDG uptake by the inflammatory cells. However, despite preparation with the ketogenic diet, incomplete suppression remains a significant issue and can lead to misdiagnosis of cardiac sarcoidosis, inappropriate immunosuppression, and increased costs to both the healthcare system and also to our patients. And so therefore, strategies to reduce and identify incomplete suppression are required. our group has recently identified FDG PET patterns resulting from incomplete myocardial glucose suppression in healthy volunteers. And we found that most cases of incomplete myocardial glucose suppression in healthy volunteers does not demonstrate the classically known diffuse LV uptake appearance. But instead, many cases of incomplete glucose suppression in healthy volunteers can have a non-specific appearance that can be misinterpreted as pathologic. And these patterns are associated with low beta hydroxybutyrate levels. These patterns in particular include the basal LV ring pattern, where there's this FDG uptake confined to the basal LV ring, isolated uptake in the lateral LV wall, or heterogeneous LV uptake that can also spare the apical septum. And therefore, given these patterns, it's critical for us to develop strategies to maximize glucose suppression and aid in the identification of incomplete myocardial glucose suppression to ensure that we're accurately diagnosing pathologic myocardial glucose uptake. And so given that, our objectives for this study were to investigate the association between ketosis, as measured by point of care beta hydroxybutyrate levels, with different patterns of myocardial glucose uptake in patients undergoing evaluation for cardiac sarcoidosis. And we also wanted to understand the relationship between the ketogenic diet duration and fasting duration with myocardial glucose uptake. And so in this study, we prospectively included 471 unique consecutive outpatients who underwent PET for the evaluation or management of cardiac sarcoidosis at our institution between March of 2021 and November 2023. And with regard to the patient preparation, historically at our institution, patients followed the ketogenic diet for 1 day. But this protocol was modified in May of 2022, where patients subsequently followed the ketogenic diet for 3 days. Patients also fasted for at least 12 hours prior to FDG injection, and all of their dietary logs were reviewed to ensure appropriate adherence prior to the scan. And then the beta hydroxybutyrate levels were measured immediately prior to FDG injection using the true point-of-care assay. And so here's how we classified negative or positive scans. So negative scans had no FDG uptake throughout the LV myocardium. But then in terms of for positive uptake, we defined that as on the baseline scan as multifocal FDG uptake with involvement of the septum and RV, and with associated matching perfusion defects or LGE on CMR when available. On follow-up scans, positive uptake was defined as persistent uptake at sites of known uptake on the baseline scan. And here's how we diagnose the non-diagnostic scans, where the classically identified diffuse uptake throughout the LV. And then the non-specific patterns were those that we saw in the healthy volunteer cohort that we previously studied. And these are the patterns that can be misinterpreted as pathologic and include heterogeneous LV uptake, lateral LV wall uptake, or basal ring LV uptake. And these are particularly nonspecific in the absence of matching perfusion defects or LGE when CMR was available. And so in our overall cohort, things that we wanted to highlight were that approximately 45% of our patients had biopsy-proven sarcoidosis. Approximately 73% of patients followed the ketogenic diet for greater than or equal to 3 days. And the median fasting time was 16.7 hours. In terms of the overall interpretation of our scans, about 80% of patients had no uptake, and 13% of patients were designated as positive. In terms of the diffuse uptake, that consisted of 3% of our population, and 4% of the patient population were interpreted as non-specific FDG uptake. When we looked at the relationship between beta hydroxybutyrate levels and the interpretation of the scan, we found that patients with negative and positive scans had significantly higher beta hydroxybutyrate levels compared with individuals who had diffuse uptake or non-specific patterns of uptake. And we found that the combined rate of any FDG uptake, including the diffuse, nonspecific, or positive reads, decreased inversely with higher beta-hydroxybutyrate levels. When we looked at the relationship between the ketogenic diet duration and beta-hydroxybutyrate levels and scan interpretation, we found that the beta-hydroxybutyrate levels increased proportionately with the ketogenic diet duration, and the combined rate of any FDG uptake on our scans decreased inversely with the duration of the ketogenic diet. So here are some examples of patients who had non-specific uptake after 1 day on the ketogenic diet with no uptake after 3 days. You can see that they had some patterns of isolated LV lateral wall uptake, basal LV ring, heterogeneous uptake, and isolated LV lateral wall. And one thing to note is that while none of these patients had uptake after following the ketogenic diet for 3 days, their beta-hydroxybutyrate levels also increased between the 1 day on the ketogenic diet and 3 days on the ketogenic diet. We also looked at the relationship between fasting time and beta-hydroxybutyrate levels, and we found that beta-hydroxybutyrate levels augmented significantly with fasting time, but we did not find a statistical difference between of myocardial glucose uptake across patients with fasting time stratified by tertiles. And so the conclusions of our paper were that FDG patterns that are suggestive of incomplete myocardial glucose suppression and a non-diagnostic study include diffuse uptake, heterogeneous LV uptake, isolated LV lateral wall uptake, and LV basal ring uptake. We also found that there is an inverse relationship between beta-hydroxybutyrate levels and myocardial glucose uptake. Found out following the ketogenic diet for a longer duration, such as 3 days or longer, is associated with lower rates of any myocardial glucose uptake. And so we thought of a potential clinical workflow to implement these findings would be to measure a point-of-care beta-hydroxybutyrate levels when patients are presenting for their outpatient FDG PET scans. And if the beta-hydroxybutyrates are very low or zero, those patients can be rescheduled after dietary instructions and following the ketogenic diet for a longer period of time. And also, if you have patients who come in and there's suspicion for a non-specific uptake, you could potentially repeat these scans after following the ketogenic diet for a longer duration. Some limitations of our study include the inability to generalize the specific beta-hydroxybutyrate cutoffs that were found in our study to other commercially available assays, and of course, the lack of a gold standard for the definition of myocardial inflammation. So thank you. I'll now defer to Dr. Bravo for some additional comments.
Thank you so much, Mahesh. That was fantastic. I'd like to discuss the study in the perspective of the investigators. So this is some work that we've been doing at the University of Pennsylvania for some time. As Mahesh showed, we started out with healthy volunteers. And it's kind of interesting because when we started doing this study prospectively, there wasn't anything published in the literature looking at the relationship between ketone bodies and FDG uptake in patients. So by the time we were actually ready to publish, there were already 2 manuscripts that had already been published on this topic, which always makes things more complicated because from the journal perspective and the reviewer perspective, there's a loss of novelty already. So when you already have something published in the same space, so that was one of the challenges, because when we submitted this work, we wanted to make sure that our work stands out compared to all the other 2 manuscripts that were already published in this space. So I just wanted to share some of the challenges when we're actually trying to publish something like this it may be perceived as novel, but if something like this has already been published, although with a different patient population or different study design, it can be perceived by others as no longer novel, and your manuscript could potentially be turned down for that reason. So we were actually quite happy to see that our manuscript, when we first submitted, was well received by the editorial board of Circulation Cardiovascular Imaging. So I wanted to say that.
Okay, fantastic. Thanks very much. Obviously, scientifically very fundamental and important work, and congratulations for your manuscript published. And then also thank you for sending this to us. So I might ask the role our editor-in-chief a couple of questions of the editorial process to begin with in general. So, for the junior faculties or junior doctors, can you walk us through about editorial process when you received manuscript from authors, and what would be the process and in terms of handling it, sort by the automated process or an AI, or even the editorial assistant, or you read through everything, or how we handle this at the Circulation Imaging?
Oh, thanks, Kaz. And again, congratulations to both Mahesh and to Paco. And let me say too, Paco has the difficulty, he's published extensively in this area. So we always have to look at what he's published relative to what is now coming in. I'll get to your question in a second, Kaz, but I do want to address Paco's concern about novelty. And yes, everybody wants to be the first one out of the gate, and we would love to publish the first paper, but 2 points are important here. The first one is we are very interested in confirmatory science, meaning, can it be somebody else, a different lab, reproduce the same results? That's important for certainty of what the results mean. The other one we look at is how well the study's done. And this study was done exceedingly well with the highest standards and a large number of patients. Other studies were smaller and so on. So that, believe it or not, this paper was an easy one to move through. I was not the AE on it, but I was closely involved with it. So that was really not a concern. So I just wanted to put that out there for Paco to begin with, and for the group, that even if something's been published before, you can still put it, submit it, just be clear as to why this one is either confirming and why it's still different and important, not just here it is. Now, getting back to Kaz's questions, I'm just going to walk you through what happens when you submit a paper to the journal. It goes through a quality assurance check by Carrie and her team. That's all the emails, everything back and forth, so it gets in the right format. It is then assigned to, we have 4 senior editors looking at papers during the course, one per week, one of whom is a guest editor. And let's say it's me that's reviewing the papers. I look at every paper that comes in that week, and I will look at them, and we will make a decision based on, if we don't think it's going to make it through our journal, we will do what's called a reject without external review. And the way we come to that decision is sometimes we can do it on our own, but typically I will consult 2 or 3 other experts and say, look, I think the paper's fine, but I don't think it's going to reach our standards for these reasons. Do you agree or disagree? And then we get it. And if anyone says, no, I think it has legs, we send it for external review. It has to be a consensus. But if not, then you'll get a letter from me saying, we appreciate the effort, but we've made this decision, and the reasons why are A, B, and C. We usually give you a few simple reasons for that. And they'll let you know we reject without external review approximately 50% of all the submissions that we get. And we do that because we want to focus on those that we think have a chance. But don't take it as a bad paper. It may be that the paper isn't a good fit for us, or we're more multimodality, a little bit further down the translational path. If this is a echo-specific paper looking at echo-specific measurement that we don't think is not necessarily novel, maybe done slightly better, we'll just say it belongs in Echo Journal. It doesn't mean it's a bad paper. The other part of that too, I want to mention, it goes through the entire process. Some papers are a little more confirmatory, not quite novel enough, but still maybe important to publish, we will send those to JAHA within our family of journals, and JAHA may take it. So it's still, we do that across all of them. It could be, EP, it could be interventions, it could be heart failure, depending. But assuming we get through those, then I will assign a paper, let's say to Fabien, and then it'll be up to him to identify the external reviewers. And we have a very large external reviewer board. It was approximately 135 people, all expert in the field. We like to use those folks because they're committed. But if we need be, we go outside that area. And then those review requests go out. We ideally want at least 3 reviews. So sometimes we only get 2, but usually 3. They come back. Then the AE then integrates what they're saying, what he or she thinks. They then generate a consult to say, here's what's going on, here's what I think. If the paper is not going to make it and it's a clear reject, that may not go to an editorial board meeting where we discuss it. We may just deal with it during consult. If we think that it might have legs, or the board meetings like the next day, that will go to the board meeting, team meeting, and we'll discuss it. And that will then, you will then get the responses back. And then from there, it just depends. If it's a reject, it's a reject. If it's a revision, you'll get the request for revisions. When those come back, they'll be reviewed again. And if we think the paper is going to continue, then we'll send it for statistical review. We don't want to overload our statisticians with all of the papers. And then it just goes through the process until it's accepted. Our acceptance rate is about 8%. So it's tough to get through. And so you don't feel badly. Our revision acceptance is only about 20 to 30%. So it's hard to get these papers in. And we made this decision early on that we are going to put out the best science that we could. We weren't going to just fill the journal for the sake of the journal. We want to have a diverse type of portfolio. That's why you'll see case reports, research letters, how to use imaging, review articles, and 5 or 6 papers per issue, with 2 or 3 maybe 2 or 3 editorials mixed in there. So that's really the process. We shoot to get everything back to you within a month to a month and a half. Obviously, some take longer for a variety of reasons. Some are shorter for a variety of reasons. But we've also made the commitment that we would rather be thorough than fast. It's not that things sit and don't do anything. They may just go through a lot of discussion amongst us, and that may take more time. And we'd rather do that than just get something back fast because we want to get the decision out fast. So I think I answered most of that, Kaz. Did I miss anything else?
It was wonderful. We have probably 12 minutes to go. So just a reminder for the live audiences, if you have any questions, please use the Q&A chat box on the bottom of the screen you can have. Then you can ask questions any of the panels if you wish. So while we are waiting the next questions, Rob, I have the follow-up questions to you. So when we send these papers to the external reviewers, we receive their recommendations, sometimes concordant or unanimous, but often some variations or heterogeneity in their responses. How would you handle if there's mixed or even opposite, the
Sure.
recommendations?
That's a great question. It happens fairly frequently. And one of the strengths of the team is we have really strong experts on the team. And the editorial team is about 20 some odd people. I'm not talking about the board, but the team. So we're getting input from all those folks. And so at the end of the day, it's really the team that makes it, and it's actually the AE that makes the decision. But he or she is getting input from the entire team, and we look at that. And there may be a variety of reasons we will disagree with reviewers' comments. Maybe the comments weren't as thorough as we'd like them to be. Maybe the comments are a little, for lack of a better word, not as focused on what we think they should be focused on. And if the reviewers' comments align with what we think, we're obviously going to go with those comments. If you review for us, you'll get a letter back. It'll say thank you and so on. Here's our decision. And we sometimes make a decision that may be counter to what you recommended. And so we will do that. As a reviewer, I've had that happen to me. I've said this paper should be rejected. Next thing I know, they're asking me to write an editorial. I mean, I don't think I can. So yes, but that's because I can absolutely promise you that at least 3 to 4 people at a minimum will always weigh in on a paper at a minimum. And that's a clear reject. That's not even the ones that go through the discussion. Our team meetings are 10 to 20 deep. So it's a lot of eyes looking at it, and it depends on what aligns with what we think.
Thanks very much, Rob, for sharing your thoughts and our editorial process. And so now I'd like to go back to the authors, Drs. Bravo and Jiwon. So in this particular papers, how did you feel about the first response or decision letters from us? It was too much ask or very challenging or very easy to handle? Could you share your thought on this?
So for this particular manuscript, we have a very positive experience with the editorial board who was involved in the review process. So I think we submitted the paper in February of 2024, the first time. It actually took us a while to respond to the review letter was pretty long. So we had 3 reviewers and 1 statistician. So there were 4 people commenting on the paper. So it really, it took us almost 3 months to actually address all of the comments because there were many of them. And so we can talk about some of those comments as well. We responded to the best we could and submitted the first revision in May. Since we spent so much time, so we think we did a good job. And so for the second revision, it was a lot shorter, and there were only one reviewer. The other ones, and that after 1 month in June, the paper was finally accepted. So overall, it was a great experience for this particular paper. Mahesh, do you want to comment on your experience?
Yeah, thank you. So yeah, I agree with Paco that it was a very positive experience. And I thought that and I think both of us thought that the suggestions that were given to us by the reviewers really helped improve the paper in terms of making it more clinically impactful and meaningful. In particular, we added some additional analyses about the whole about our population wonder-and follow-up scans, which I think which we agree is a very important population to include. And then one comment that we both really appreciated was that there was a suggestion to add a proposed algorithm about how to implement our findings into a nuclear lab. And so we, when we first talked about this, when we were first designing the manuscript, we were hesitant to include this as given that we had not validated our algorithm, and this is something that we were thinking about using in our lab. But I think being able to get that suggestion and being able to think about how to best craft our results into creating a proposed algorithm with the understanding that the readers would understand that this is not something that's been validated, but something that they could potentially think about for future studies, but also think about how they would implement their lab, was something that was a very nice suggestion to us, because I think it made us think about how to make our research the most clinically meaningful and impactful for the readership.
And I would like to add about the algorithm. Sometimes you don't want to look overly ambitious when you actually present something like that straight away when you first submit the manuscript. So you have to be concerned about just presenting data and then proposing something out of that data that has a clinical impact. But in our case, all of the reviewers were asking for it, so that was very helpful.
What, Kaz, let me just add one. I think this is a little tangential, but it was brought up in the earlier discussion too. I do want to encourage that if you are unclear as to how to answer something or what's the next step, send me an email. We'll engage the AEs or myself, whatever, and we will, help you with that. I'm not asking for a lot of emails here, but I do think that there are times when things aren't clear. We try to do that in our letter. If there are conflicting reviews, we try to have our AEs, or if I'm writing a letter, to say, hey, this is what you want to focus on. These are the key points. But if we fall short on that and you're not clear how to answer something, let us know. Or if you do, if you disagree, you're always welcome to email. I will say, though, you're always welcome to appeal. I can say that the overwhelming number of appeals are denied, but they are reviewed. I mean, it's not just, no, forget it. We will go back and look and talk about it. And we have reversed some decisions. So it has happened. So I will just put that out there as well.
Thanks very much, Rob. It's a very important point. There's a channel to, communicate with us. It's not the, one-way process to dealing with. Okay, thank you very much. That was very interesting discussion. We discussed 2 papers so far, and in the scientific component as well as editorial process. So maybe another question to all the panels. So then, if we anticipate early career researchers as an audience, what would be the best way to get involved in peer review process if they wish to, and then develop their reviewing skills? Anyone could take these questions?
In terms of the easiest way? Well, I don't know who you want, but I'll throw this out there for people that are interested. For those that are early career and we do from our editorial board, I mean that the reviewers, we have a peer review training program. And every 2 years, we accept new applicants. Typically, they're nominated by somebody who's an editorial board member from their institution. And they then spend 2 years being reviewers and under guidance. And those that are, do really well are asked to stay on as editorial board members. For more other, further along phase, you're free to send me an email and a CV. So I would love to be an editorial board member. And then one of our senior associate editors who is in charge of that component will look at that and we'll discuss it and make a decision. So there's a variety of ways. Look, we're always looking for good people, strong, subject matter experts that want to be part of this. And I think those are the simplest ways.
That's another great news for the early career researchers. We have our doors are open for any time. So Jiwon, we are almost time. Shall we wrap up the session? Before that, if anyone from the panel, do you want to share any comment before we finish? Okay, Tom, go ahead.
Yeah, I think for the early career researchers, I just want to say believe in your science and persevere with the process. Obviously, you want to listen to the editorial board and get a senior to read between the lines, because sometimes, particularly early in my career when I got letters back, it's a hard sink. And I think you basically need to read between the lines, take a deep breath, perhaps a day later or so, as Professor Gropler said, and then come back and carry on. So, and you get your research, if it's good, into a good journal in due course. I think that's what I've learned.
Right.
Perfect.
Jiwon?
That's fantastic. Thank you all so much for all of your contributions, your insights. This is incredibly helpful. I think our audience has learned a lot about the peer review process and the inside scoop, if you will. So we really appreciate your time and your efforts.
Jiwon and Kaz, thank you so much. Appreciate your hard work.
Thank you very much.
And the speaker.
And thank you, everyone.
Yeah, bye-bye.
Thank you. Bye.
Bye.
Thanks
Bye-bye.
very much.
Bye.
Thank you.